tutorial giving the foundations of the basal ganglia and the movement pathways. Those are your direct and your indirect pathways. These guys come up a lot, so you're going to come to know and love them, or probably know and hate them, in my case. And these guys took me like a solid week and a half to understand. So there's some high yield stuff and low yield stuff. I'll try and point out to you what's high yield. Again, there's notes to follow in the description. And don't get lost too much in the detail. Just remember the main things is the pathologies at the end and basically the summaries of the pathways. Okay, what are the basal ganglia? So basal meaning base of the brain, and ganglia meaning collection of neurons. So essentially all they are is a collection of neurons at the base of the brain. So here we have our axial kind of slice of the brain. So axial means from front to back, and here we have an MRI. You can tell it's an MRI because there's not like a white outline which you would see in a CT scan. So here you have your anterior lobes, and these are kind of your prefrontal cortex, and here you have your temporal lobes. You can see that here, your temporal lobe here, and your frontal cortex here. Okay, so first thing here is your ventricles. It really confused me a lot what even are the ventricles. So basically it's the drainage system of the brain that circulates the CSF around the brain. So the ventricles are responsible for draining the CSF, as I said. And so here you have your lateral ventricle on this side, and you have your lateral ventricle on this. You can't really see the other bit, but there's another horn on this side. And in the middle here, you have another hole, and that's called your third ventricle. There's a diagram in the kind of sagittal view, which shows a fourth ventricle, but I hate that diagram, but again, it'll be in the notes. Essentially, I don't even like the numbering. The numbering doesn't make sense, but anyways, you have to know the numbering. But there's the lateral ventricles and the third ventricle. The third ventricle, underneath this, will be something called the cerebral aqueduct, which is basically like a little tube, and this is going to connect to your fourth ventricle, which is at the base of the brain. And the fourth ventricle has gaps in it which allow the cerebral spinal fluid to flow in the subarachnoid space. So just briefly, there's a video on meninges and meningitis, but here's the skin, here's the bone, here's our first layer, here's our dura, which folds into form the falx cerebri. Underneath it, you've got your arachnoid, and then your pia, and between your arachnoid and your pia matter, you've got your subarachnoid space here, which is in green, then you've got your grey matter. So your fourth ventricle basically has holes in it which allow drain the CSF there from kind of the ventricles and allow it to flow into the subarachnoid space. Lovely. So our first thing that you can kind of see here is a darker patch here, and this is called the caudate nucleus. And then if you go across here, you can kind of see on both sides, there's a darker kind of shaded bit here, and this is called the putamen. So you can see this here, there's a much darker grey bit here. And again, you might be asked to identify these on an MRI, for example. So that's your putamen. Okay. You can kind of see, because they're darker, they're more striated, right, than the rest of the kind of brain here. They're called the striatum. So the caudate nucleus plus the putamen are called the striatum. And again, these are responsible for your they're important in your basal ganglia. Okay, then you can see here something that's dark, but it's paler dark, and therefore it's called the globus pallidus, pallidus meaning paler. And you've got two sections, and here you can see kind of there's a external segment and an internal segment here, separated by this kind of white border. So this is your globus pallidus, meaning paler, and it's got two sections here, and you can see it just here as well in front, slightly lighter than the putamen here on the MRI. That's your globus pallidus. And I don't know if you can see it, but these two, the globus pallidus and the putamen, kind of form a lens shape. I mean, if you can't see it, just pretend you can see it. And the Latin for lens is the word lentiform, so know that these two together, the globus pallidus and the putamen, are called the lentiform nucleus. Coolio. Right, then we've got our thalamus. This guy is important for movement, and you can see it here. Thalamus on this side as well, and off the ventricle. You can't see it here, but you won't be asked to label it either, but you've got underneath here, you've got your subthalamic nucleus, and then finally here you've got your substantia nigra, so nigra meaning darker. These are your kind of darker neurons in the brain, just below the thalamus, and they as in posterior to the thalamus, these guys produce dopamine, so they're important. I mean, they're important for everything, but they're important especially in Parkinson's. This guy here is called the internal capsule. He's not really that important in terms of the direct and indirect pathways, but because we're here looking at this area, I thought I'll talk about it. So you've got the genu, which means flex. So your genu is your bend here, and you've got the anterior section here, and your posterior section of your internal capsule. Again, you can see your internal capsule on this side here. Again, so this is not really important for the basal ganglia, but it's important. So your anterior section, your anterior limb, what it's called, contains fibers that are responsible for worrying and like stress, anxiety kind of thing. And the posterior section is important for your contralateral motor and sensory supply. These guys, so your posterior limb is supplied by your striate arteries, which is a branch of the MCA. And therefore, if you have a stroke here, this can lead to complete paralysis on your other side of the body and also contralateral sensory loss. And these types of strokes are known as lacuna strokes. Okay, right. So what is the point of the basal ganglia? So the basal ganglia, these guys, they're basically, their aim is to make movement more fluid, more smooth, basically. So there's the direct and the indirect pathway. The direct pathway is going to increase movement. The indirect is going to inhibit movement. And together, that's going to help you make fluid, nice, smooth movements. Ready. So we'll kind of start here with thalamus. Now, it's not actually important. You're not going to be asked to draw these pathways on a brain because they kind of go all over the place. So you can look at the notes and kind of refer to them, but you won't be asked to draw, trace out the exact pathway of the brain to my understanding. But you'll need to know these things. So you have your thalamus, let's start here, and your motor cortex, and this is going to have a excitatory glutamate production. So green arrows mean glutamate, which means excitatory, And this is basically so your thalamus is going to excite your motor cortex, which is going to lead to movement. So nice and simple so far. And we'll start off with our direct pathway. So if you have a look at your globus pallidus internal, and there's another part of your substantia, basically your substantia nigra has two parts. A part called the substantia nigra pars reticulata, so you know that part, SNPR. This has a inhibitory connection to the thalamus. So if the thalamus leads to movement and you're inhibiting that, you are going to be causing a reduction in movement. So basically this blob from 2 onwards is going to reduce movement. Alright, so far so good, hopefully. And if it's not making sense, then just kind of watch this again, try and complete my sentences, and hopefully it makes sense on the second time. So again, we're talking about our direct pathway. We've started off with inhibiting movement, and what happens is your striatum, good old striatum, the caudate nucleus and the putamen, remember, which are the darker bits. This has a GABA inhibitory projection to this kind of blob, to your GPI, and if you're inhibiting this, you are going to be you're inhibiting inhibition of movement, which means you're disinhibiting movement. Basically, the direct pathway leads to movement. So far, so good, to be honest. And essentially how it works is when your body wants to move something, it will send a fibers from the cortex, so from your thinking bits of the brain, excite the striatum, and the striatum, by the direct pathway, will inhibit this inhibition, so leading to disinhibition, leading to nice smooth movement. Alrighty, so let's talk about our indirect pathway. I said our indirect is going to inhibit movement. So if we start with our subthalamic nucleus, this is going to have an excitatory input to this blob here. Remember, this blob reduces movement, so if you're increasing the reduction of movement, all you're going to do is you're going to reduce movement further. So your subthalamic nucleus, the role of that is to lead to less movement overall. Again, this can be quite complex, but build your way up, alright, and try and understand the basics. Okay, so as we said, this is going to lead to less movement overall. This is what we've got so far of our jigsaw of the indirect pathway. If we continue our jigsaw, you've got your globus pallidus external and your other part of the substantia nigra, which is called the pars compacta. But that's content, but to be honest, it's not high yield. So all you need to know, essentially, well, I mean, you can know the other one, but all you can focus your knowledge on is knowing the globus pallidus external. So the globus pallidus external has a GABA, so inhibitory input to your subthalamic nucleus. So if your subthalamic nucleus leads to less movement overall, and then you're inhibiting the less movement overall, what are you doing? You're going to cancel that out. Basically, you're leading to more movement. Okay, our final step is our good old striatum, as you would have guessed. This, again, so it has a GABA connection to your globus pallidus external. So the globus pallidus external, if we go 5, 6, 2, 3, 4, that is going to lead to movement. But the striatum is going to inhibit that, so it's going to inhibit movement. So it's going to lead to no movement. Okay, if you can't, if this is frying your brain knowing about all the GABAs and all these different colored arrows, just focus on knowing that the indirect inhibits movement, the direct leads to movement, and know that the GPE and the subthalamic nucleus are involved in the indirect, and know these nuclei as well. But yeah, as I said, if the arrows are worrying you, then you can give them less attention, basically. Okay, these are our pathways. Basically, they can be modulated by dopamine, and dopamine in both kind of pathways will lead to an increase in movement overall. Okay, so dopamine is released by the part of the substantia nigra called the pars compacta. Know that one, please. And this is going to release dopamine onto your striatum. And so it's going to go from the substantia nigra to the striatum via something called the nigro-striatal pathway. And there's basically 2 receptors on the striatum, one for each pathway. So we'll start with how does dopamine affect the direct pathway? Well, that's through the D1 receptors. And the D1 receptors, they are going to be excitatory upon dopamine. So this is basically, dopamine is going to increase the amount of GABA from the striatum. So it's going to increase these inhibitory projections, which means that you are decreasing overall the reduction of movement, right? So you're basically increasing the disinhibition, so you're basically amplifying the direct pathway. So the substantia nigra, when it releases dopamine, it's going to increase the direct pathway. Notice how I've written direct pathway as in D1 rect. Yeah, so that's kind of how you remember that the direct pathway involves the D1 receptors. Okay, so it leads to movement. And our striatum also has D2 receptors, which are inhibitory. These are going to act on the indirect pathway. And basically, so when dopamine hits these D2 receptors, these are going to cause this GABA production to decrease. So if you're decreasing this, then the GPE is not going to be inhibited as much, right? Even though I'm getting confused now, but if you're decreasing the inhibition to this, then this is not going to be as inhibited as much. So the GPE is now going to be more active, which means these GABA projections will be increased, which means what? Your subthalamic nucleus will therefore be decreased, right? It will have decreased activity because it's getting more inhibition here. Therefore, your subthalamic nucleus is going to be less active. And remember, your subthalamic nucleus leads to less movement. So if your subthalamic nucleus is less active, then you're going to have your indirect pathway turned down, your thalamus excited more, leading to more movement. So, as you can see, both pathways dopamine leads to more movement. Again, so the high-yield thing is to know that dopamine acts on D1 for the direct, D2 in the indirect, and leads to more movement. It's useful if you know these, but don't fret about it, to be honest. Okay, in both pathways, dopamine leads to more movement. Okay, we're now going to briefly touch on the pathologies, some of the pathologies involving this. Okay, so we said the direct pathway leads to movement overall, and indirect leads to inhibition of movement, so indirect inhibition. And when the Substantia Nigra pars compacta releases dopamine, it's going to increase the direct pathway activity, leading to more movement. And on the D2 receptors on your indirect pathway, dopamine is going to make your subthalamic nucleus less active, meaning your thalamus is excited more, leading to more movement. So the conclusion is that in both pathways, dopamine leads to more movement by turning up the direct and turning down the indirect. Okay. All this stuff is high yield. Okay. Let's talk about, so our first pathology we're going to talk about is Huntington's disease. And basically, the function of the basal ganglia, as we said, is to make nice, smooth, fluid movements. So when you lose that, you're going to have these movement disorders where are characterized by kind of problems with movements, right? So the first one is Huntington's disease. And there's two pathologies you need to know. The first one, or pathophysiology, is one mechanism that is kind of proposed, is that there's too much dopamine being released. So if dopamine leads to more movement, basically you're going to get overstimulation of these receptors. And if dopamine leads to more movement, and in Huntington's you get too much dopamine initially being released, then you're going to get hyperkinetic, so you're going to get like tremors. Notice I've said the initial stage of Huntington's. There's going to be a video about like Huntington's in more detail, but this is the initial stage. There's a different pathology for the late stage of Huntington's, which causes akinesia. But your first stage is going to be hyperkinetic. And therefore, how are you going to treat it? Well, if it's caused by too much dopamine, you can treat it with dopamine depletion, and you can give a therapy called tetrabenzene, which is an antagonist of dopamine, and tetrabenzene is shown to kind of help control the tremors of the tremors of Huntington's. Cool. Okay. The other kind of pathology that you need to know about Huntington's, proposed pathology, is that in the indirect pathway, the striatal projections to the GPE are going to be degenerated. So this is in the indirect pathway, which means your GPE and your Substantia Nigra pars reticulata are going to become more active. Therefore, your subthalamic nucleus will become less active. Therefore, it will become less inhibited to the thalamus, leading to more movement. So both these pathways, and again, you might want to look at the notes just to follow what I'm saying. But if you're if you're degenerating the indirect pathway, and remember the indirect pathway leads to inhibiting movement, then you're not going to be able to inhibit movement as much. So therefore, you're going to get excess movement, so hyperkinetic. Okay, Parkinson's is much easier pathology. And Parkinson's, you might have seen it with like it's characterized by something called bradykinetic, sorry, not bradycardia, so meaning slow movement and hypokinetic. So in Parkinson's, what happens is your Substantia Nigra, the guy that releases dopamine, that increases movement, is going to degenerate, and therefore your thalamus is going to so there's less dopamine basically. Your thalamus is going to become more inhibited. Remember, the thalamus excites movement, so your thalamus without dopamine is going to become more inhibited, leading to, in Parkinson's, hyperkinetic disease. So this causes rigidity and bradykinesia. And also remember, this affects the fluidity of movements, so you get something called a resting tremor in Parkinson's, also called a pill rolling tremor. Again, there'll be a video on Parkinson's, but this is to introduce you. Okay, so if Parkinson's is due to low dopamine, you can treat Parkinson's with a dopamine precursor, and a precursor because dopamine itself can't cross the blood-brain barrier. But if you give a precursor called levodopa, L-dopa, then this can kind of replace synthetically the lack of dopamine from the Substantia Nigra. Okay, our third disease is called Ballism, and this is degeneration of your subthalamic nucleus. Remember, your subthalamic nucleus is your part of your indirect pathway, and this leads to reduced movement, so normally. But if your subthalamic nucleus degenerates, it's no longer going to lead to reduced movement, again, so leading to hyperkinetic large amplitude movements.